As David mentioned, I am, I'm less a sociologist than an historian, and you might have noticed that in the way the paper is written. But I've indeed been working on issues of health and society for now quite a long time. Is it okay you hear me or not? It's okay, fine, thank you. And so what I will do now is actually to well, give back the basics of the argument as I'm making in the paper, give you some complementary information and background to better understand what it is about and why especially this experience of the Kerala social development policy is interesting and important. And say, I have to remind you that Kerala is not a nation state. It's not an independent state. It's a part of India. It's a regional state because India is a federation, and it is located in the south of India, in the southwest coast of the country. So first thing I like to say is that this work, this research I have done in Kerala on the health policy of the state is part of a broader project that I conducted with both anthropologists and historians in the past 10 years. And it was a project it was a collective one, trying to understand what happened in international health. So when I say international health, it is the field organized around WHO, the series of international organizations like the World Bank, and of private foundation like the Melinda and Bill Gates Foundation, which intervenes in health and support and organize intervention program in health at the international level. So basically, it is about initiatives which are funded and framed and organized in the North and which target what we call now the low and the middle income countries. And this project had two specificities. I mean, the first one is what I mentioned. It was a project gathering historians and anthropologists, and I will tell you a little later why this was important. The second thing is that we conducted a series of inquiries about the ways health is governed and what kind of expertise goes into the establishment of health systems and health interventions at several levels. I mean, it was multi-scalar investigation working on international initiatives and actors, on national initiatives and actors, and on much more local developments and local events, as you might have noticed in the paper. So that's the main background. This program is now over, and there are a couple of books among which this kind of synthesis of what we learned about global health, that is the way the field has changed starting in the 1990s at the time of globalization and when neoliberalism became extremely important in the ways health interventions internationally were reorganized. Second thing, and this is one of the quotes I used in the paper at the beginning of it, is why Kerala? And well, the point of departure is actually what Jean Drèze and Armatya Sen, you might know, write in her book on India and social development, which is the fact that Kerala has been used as an exemplar of successful social development. And this is in very strong contrast with the overall situation in India. And the book of Gendrez and Amartya Sen, from which this quote is taken, is an overall study of why social development has failed in most of India, apart from a few places, among which Kerala. And in the 1990s, you might remember that it was also the time of the not only of neoliberal globalization, but also of the alter globalization movement. The case of Kerala was used in different ways to discuss the difficulties and the limitation of development, but also the possibility of some social success in the field. And Kerala was used in different ways. For instance, for the World Bank, what was at stake was less the question of state intervention, as it was the case in Drez and Sen book, than the demonstration of the success of investment in human capital. And we'll see later why the World Bank had this alternative interpretation of the situation in Kerala. So it's a good case to discuss more broadly, using health as an entry, the problem associated with development policies. And among the reasons why Kerala was considered as a model case has to do with the fact that if you look at basic development indicators, quality of life indicators as they are labeled here. For instance, life expectancy, adult literacy, infant mortality, or the birth rate. Then Kerala has indicators which are in strong contrast with the situation in the rest of India, and indicators which somehow are in the same range, in the same magnitude than what the situation is in countries which were at the time considered as very successful in Asia, for instance, Korea, or in the same range or magnitude as indicators in Southern Europe, for instance, for the infant mortality per 1,000, which was very low for low and middle income countries like India at that time. So that's what makes it interesting, and what makes it even more interesting is that this is utterly paradoxical, because in contrast to what most development theories presuppose, this was achieved during the 1960s and the 1990s, up to the 1990s, with a very, very small growth rate in Kerala, which was the average was 1.5% annual growth during the whole decades from the early 1960s to the early 1990s. So the paradox was what may be called a case of inverted development, which is you have development with social development preceding growth instead of what was expected, which is growth, and then having the means of social development, especially the investment in education and health. Where is? Here it is. So see if we take health as an entry point, well, what was pursued in Kerala during these decades was a policy of access and care, which historians have considered to be part of what was called at the time the primary healthcare movement. And here you have a graph showing the frequency of use of the term primary healthcare in the Google Books databases. So, which means it is the frequency of the term in mostly English literature. And you see that primary healthcare was very much used from the 1970s to the 2000, and then drop very rapidly. And it is actually very parallel to another term which has become much less used nowadays, which was the term of third world. And this is not coincidence. I mean that primary healthcare was a peculiar form of social medicine, a form of social medicine which was invented in the third world and for the third world, and which was in the late 1970s endorsed by WHO. And we will come back to that, and became the official strategy of WHO for during the 1980s and the early 1990s, but was the WHO commitment was based on previous experiments which had taken place in many nation states of the third world. So it is important to remember that the case of Kerala is actually part of this large movement to try to invent a form of health system which is adapted to the realities and the needs of the third world. So what I'm going to do is to recapitulate the argument of the paper and give you some complementary information. So the first part about people's health, community mobilization, and state policies. So as I was saying, primary healthcare was a strong commitment of some states to investment in health, but with the specificity of trying to acknowledge and take into account the limited resources countries, most of the countries in the third world had at their disposal, and how they could, but they could engage. So it was a commitment to a form of medicine which said, and which tried to offer the guarantee that the basic care would be provided, and that basic care would be provided by trying to focus or to prioritize basic health needs. Of course, one of the big discussion was what the meaning of basic health needs, and this was a good, great issue, but this basic health need making the possibility for the healthcare system to provide this care to all citizens, and with a strong priority, as I have mentioned here for the case of India, prioritizing the creation of local health centers. So, I mean, the target for India overall after from the beginning of the independence of the country was to create more than 5,000 local health centers, one per district. In the case of India, primary healthcare was on the agenda already in 1946 with the first committee on the health policy to be developed in the newly independent country, but it remained at the federal level mostly a discourse without much implementation, or rather said with a kind of superficial implementation. And one reason for that was that in the Indian constitution, health is not a federal, it's not a central affair. It is a state matter. So it falls under the jurisdiction of the regional state like Kerala. So that the main type of intervention the federal state was providing was the mediation between international programs and the state themselves. So it was the running of programs based on international intervention. For instance, the Indian malaria program was to a large extent funded by international organizations, including WHO, and this was a state affair. So this means that in the implementation of what was thought as the primary healthcare policy early on in India was very unequal among the different states. And Kerala is one of the places, there are 2 or 3 others, one of the places where a kind of primary healthcare policy was pursued somehow before, during, and after WHO engaged in the support of that kind of health policy. And this relied on the fact that soon in the history of the Kerala state policies, there was a kind of consensus, of political consensus about the importance of health and education as targets. And this consensus has actually resisted the changes of political government. I mean that there were 2 big coalitions running the state. I mean, one center-left coalition, which was associated and led by the Congress Party, which was the main party in India after independence in 1947, and that Congress alternated power with the Communist Party of India, a left coalition, and none of these coalition, when they alternated in power, actually cancelled or suppressed the investments and the measures taken in favor of health and education by the other coalition. So in the state, if we focus now on Kerala, the main actor at state level in health policy was what was called the Department of Health Services. And we are actually lucky in the sense that we can investigate the history of these policies thanks to a good archive, which is the State Archives of Kerala, where all the material related to the action of the Department of Health Services have been kept and there are some restrictions, but more or less accessible. And this is what I have used a lot to investigate this. And for instance, here you have an example of a memo circulating within the department, which discusses an element of planning adopted for the year 1972, which was the launch of a campaign to open 200 local dispensaries during that year, which is given the size of Kerala at that time had 15 million people, which was very important. And actually all along the 1970s, there were that kind of schemes which were adopted. And for instance, here in this memo, you see how such local health centers would be organized, saying that the personnel to man the center should be one doctor, so one surgeon, one nurse, one clerk, one attendant, and one sweeper. And this was the very, very basic, the most local unit of the health service. So if we consider the entire period from the late 1950s to the 2010s that we have investigated, I mean, we can offer a kind of periodization, which was not presented as such in the paper, but is underlying what we talk about. And I give you the main point. I mean, the first years were years of creation of the state, of integration of the existing dispensaries, because I didn't mention that, but Kerala was only created 10 years after independence by the reorganization of the borders of the colonial boundaries of the provinces the British had established. Then there is a development which is almost by decades or so. So the 1960s, 1950s, you have, as I have mentioned, the opening of hundreds of new dispensaries and primary health centers. Was a kind of support to these initiatives by less WHO than UNICEF. Then the 1970s, 1980s is a time of repeated political mobilization, actually to open some centers in non-privileged areas, but more importantly, to increase the size and the bed strength of all centers in the state. And it is a time of systematization of the coverage of the district. Then, when we talk about a little more later, the 1980s, early 1990s, that was a time of economic and fiscal crisis in the state. And from the late 1990s onward, you have another period, which is in a way symmetrical to the 1960s, 1970s, a second period of enlargement and reinvestment into health, which was based on laws on decentralization and local planning, which were passed in 1996 and radically transformed the situation. So I mentioned the state's archives, and they are extremely interesting and important to document the state's action and the vision of health that was prevailing at this level, but it's not enough. If we want to understand what primary healthcare meant, what happened in practice, and how people related to the state policies, then you need to do some kind of very local history, I mean, what the historians call micro-history. And to do this, because the archives have been created at a much bigger level, it's difficult to hear the voices of villagers, the voices of workers, the voices of local doctors, and so. And there are some correspondence, which is interesting, and you might have noticed that in the paper. But you need slightly different methods than those the historians used to implement, and we need to borrow from anthropology and sociology. And that's what we did, which was to combine the archives with interviews and visits to local centers. And one of the centers for which we were very lucky, because there is a whole series of documents in the archives, and we could go there and discuss with people and learn more about the very recent period and get a sense of what the place is about, is the primary healthcare centers of a place called Virginia, which is a small, well, not so small nowadays, but a place where mostly fishermen are living. And it was one of the places where very early on there was a primary health center created. So the part of the paper is based on the local trajectory of this center. So that was my word about the sources. So one of the outcome and one of the important results in what we did about Virginia and other centers is that we could document the local mobilization. I mean that these local health centers could only exist through a whole series of activities which were associated with the the building of the site itself, so the construction work involved in having a place where to organize care. It was they existed only through the staffing which was provided by the state. They could work only if there were all series of supplies which were provided, the supply of drug, the supplies of some equipment, the supplies of some transportation means, because given the size of the district where the centers were created, it was impossible to provide care only within the walls of the health center. You had to also visit the distant villages. You had to visit houses and places, especially to conduct public health interventions. So there is this whole series of activities which actually involve the state, but sometimes involve much more than the state. And the creation of the health infrastructure in Kerala could not have happened without the local mobilization. I mean, there was a constant pressure on the state itself, for instance, to open a center in a new place or to create new beds in the places. And this pressure was, this is what I developed in the paper, associated with two types of activities. There were local mobilization, as I say, for instance, meetings, the writing of petitions, and so. And there were a second layer of activities, and this is what this quote reminds you. It is in the paper. It is an example of the mediation work. Medical officers, as well as local party members, or when I say party members, it could be either Congress or the Communist Party, and local deputies like this Vishwambaran writing to the Minister of Health, representing the constituency and saying that, and for instance, here he is reminding deputation he made in 1971 to make a plea for the creation of primary health, the extension of the local primary health center, to no avail. I mean, at that time it didn't work, but the whole story of the primary health center in Vizhinjam is full of that kind of mediation. So that's one big result. Another big result, and very original and unexpected outcome for us, is that the Kerala policy for primary healthcare included very specific commitment to the support of Ayurveda. Ayurveda is a system, it's a system of traditional medicine in India, and Ayurveda was actually recognized and officially supported by the Indian state from the time of an independence onward. And in Kerala, this commitment was especially strong, since in contrast to what happened at the level, at the center level in New Delhi, where only a few percent of health investment were associated with Ayurveda, in Kerala it was 30 to 40%, depending of the year. And so here you have an example in the archives where they discuss the opening of the equivalent of the allopathic Western medicine oriented health centers for Ayurveda. And this was part of a policy which is very interesting, which was the juxtaposition of two systems in a way. The result of this commitment was that traditional medicine was integrated in the health system, but it was integrated as a juxtaposition of two infrastructure. And this is what this picture summarizes. So you had at the bottom the equivalent of the primary health center or sub-center with the Ayurveda dispensary, and with medical officer as well. So the personnel and the training was copied or mimicked from Western medicine. Above this primary care infrastructure, you had the hospitals in both instances, the Taluk hospitals or the Ayurveda hospitals. And at the top, you had the training centers, the medical colleges on the one hand, the Ayurveda college on the other hand. So, and this is quite visible in the archives. I mean, the part taken by Ayurvedic medicine, including the production of drug for the Ayurveda system, was one major investment of the state. How much time do I have left?
I would say 10 minutes.
Okay, so then I had something about the relation to WHO as a kind of complement to the paper. It's interesting because to ask this question, because what I have described happened without any connection, any serious connection with WHO. And it shows how the primary healthcare policies were invented locally in a way. They are invented in many of the third world countries, and it is only in the late 70s that WHO got strongly interested in these policies. For instance, in China, the barefoot doctor medicine. So I will skip the discussion about the way the WHO strategy was discussed and framed in a way, and how it related to the local or regional example or state-based examples of primary healthcare policies. We just mentioned a few features regarding the convergences and the differences between what the strategy adopted by WHO and the World Health Assembly, and what happened in Kerala. I mean, one of the first thing is that the core set of activities which were targeted, because their prioritization was indispensable, were more or less the same. So there was a strong priority to organize the control of infectious diseases, the control of epidemics. So that was a shared feature. Then there was a commitment to what was called socially acceptable appropriate technology. And appropriate technologies, it has somehow to do with cheap, simple, and technically solid or strong technologies. And for instance, there was a big discussion, and it was much stronger at WHO than it was in India and in Kerala, about the question of drugs. And what WHO chose to do was to support drug policies, including two major elements. One was the establishment of a list of basic essential drugs. And you can imagine the discussion, the tough discussion about what essential means. And one choice was to say that all essential drugs have to be generic. And the second pillar of the drug policy was the idea of local production. And this was present internationally, supported internationally, very visible in Kerala. Another element was the question of task shifting between doctors and paramedical personnel. And WHO supported the training and the hiring of what was called community health workers, which are workers working, they are members of the community, trained to provide care on a part-time basis, and so focusing on very, very essential diseases or clinical problems. So community health workers were not very much developed in Kerala, and this was a consequence of the strength of the left in the state, because the majority of the physicians, medical experts, health personnel engaged on the left considered that if primary healthcare was good, primary healthcare should not be poor care for the poor. So that was a big issue, was to avoid a kind of substandard, subperforming medical system. And for them, the community health workers, even if they could play an important role in facilitating the participation of the community, because they were part-time, because they were trained quickly, were not competent enough. And therefore, it is only very late, after 2000, that community health workers started to exist in Kerala. And the last thing I mentioned very quickly is that the integration of traditional medicine was much less strongly supported by WHO than it was in Kerala. So now I finish with the summary of what is in the second part of the paper. So as I said, the 1990s was a time of economical and fiscal crisis. I mean, you have the same situation in many third world countries, linked to the debt crisis and the resulting in the structural adjustment policies by the IMF and the World Bank. And in the case of Kerala, this economical and fiscal crisis was also rooted in the lack of growth, which was becoming a problem. So you have a kind of paradox, because Kerala became visible internationally exactly at that time. And here I have put two quotes of uh, Kerala politicians which were complaining that Kerala was having this international recognition exactly at the time when it was facing so much problem. And as Thomas Isaac was explaining at the time, the contemporary crisis that Kerala faces underlines the limitation of what can be achieved within the present system. And the absence of economic growth for him was the main issue regarding this limitation. The consequence, as explained in this study done by one public health expert who would become health secretary in the early 2000s, was a series of cuts in the state investments in health, and the fact that there was a shift of the people toward the private clinics, and the phenomenon of mounting inequalities within the system. However, by the late 1990s, there was an economic turning point. I mean that growth started to accelerate, so reaching 5-6%. And this growth was a very peculiar one because it was triggered by the remittances of expatriates from Kerala working outside, mostly in the Gulf countries, but also in UK or in the United States. And these expatriates were sending money back to the country, and by the 2005, this wave of financing had become so important that the remittances comprised over 30-40% of the GDP. And this way out of the crisis is interesting because it shows how the investment in social development of the previous 2 decades had been successful because they had resulted in strong education policy, and the fact that Kerala would export 2 different kinds of labor. It would export unqualified workers, for instance, working in the construction in the Gulf, but also very qualified migrants and nurses and doctors actually worked in very great number outside the countries from this period onward. So that's the first important change that took place, but this could have led to a growth of use of the private health sector. But what actually countered this possibility, countered this move, what made possible reinvestment in the public health institution, what restored the attractivity of the public health institution was the passage of the decentralization law of 1996. As briefly explained in the paper, this was an initiative taken by the left coalition, by the Communist Party, but it was a phase with a reform for decentralization, which was also pushed by the government of India. And it resulted in a massive transfer of budget to the panchayat, which are the municipality, the equivalent of municipalities in Kerala. And in the case of health, 30% of the budget were passed to organize the local government of health, local government which should take place through local planning. just to remind you, it's described in the paper, the different stage in which local planning was happening. Local planning was based on assessment of local needs and resources through deliberation at the level of wards. So its neighborhood is much smaller unit than the district. Then priorities and putative projects would be discussed at the municipal level in plenary session. And once a year, a plan would be built on the project, voted in this assembly. And then there was a process of interacting with technical experts, with the administration relevant to the type of project. So it could be the health administration, it could be the transportation administration, and so forth, in order to finalize the details. And then the local government bodies were mandated for implementation. This was rooted in the social movement of the 1970s, 1990s. I don't develop that, but one of the social movements was the Science for the People movement. And this movement conducted literacy campaigns in the 80s and then committed themselves to local planning. So in the case of Virginia, for instance, this development plan during the first year of local plan, the first decade actually of local planning, favored a kind of reinvestment in the same targets that those which had been followed in the 70s and 80s. I mean that, well, this is what we see here. Sanitation and public health were the main objectives and what locally the people demanded, and the kind of project they supported, with, in addition, the strengthening of Indian systems of medicine. So you see how the support of Ayurveda was something which was based on the demands of the people, and to a less extent on what the medical experts at the state level would support. So this is basically what decentralization brought in the first phase. That was to reinvest the control and the intervention against against infectious diseases. But there was a second phase in the late 2000 and where the new resources which were associated with local government and the remittances gradually shift the objectives and the targets of the health system. Gradually, some municipalities, some places started to create dispositives, for instance, a consultation or a special ward in a center, that would not focus on the care of epidemic diseases or the prevention of epidemic diseases, but would focus on chronic diseases. And chronic diseases, meaning, for instance, the diabetes or obesity, so things related to food and alimentation. Chronic diseases, it would mean hypertension and the risk of cardiovascular disorders. It would mean the treatment of pain. So all these initiatives actually started very locally with and asked direct response to what the people were actually asking, and these new demands, these new expressed needs were actually part of what the epidemiologists in Kerala could document and describe as the major sanitary transition from epidemics being the most important cause of death to chronic diseases becoming the most important one. So the decentralization actually permitted a series of experiments which gradually generalized, and after 10 years of that kind of move, finally the state decided to endorse the commitment to the care of chronic diseases. And then the state launched state-wise programs, for instance, targeting the prevention of hypertension. Well, when you may ask why the state was so slow and so late at reacting and taking into account these new demands, well, I'll leave that for the discussion if you want. I will just so that was a quote just to illustrate this move toward the endorsement at the state's level. So I will just conclude with 3 remarks. First, the case of Kerala, I think, is a good demonstration or a good argument for downscaling actually our studies of global health and practice a form of more locally, more micro-oriented, but interscalar, nonetheless, type of history. The second remark is that I mentioned the difficulties in the 1990s of primary healthcare. At the level of WHO, it was much more worse. I mean that with the neoliberal globalization, primary healthcare was no longer considered as a valid and performing strategy, and it was given up by WHO to the benefit of much more strongly targeted programs, usually focusing on just one disease, leaving out investment in the health system as such, and mostly organizing access to drugs as the main way of treating diseases. And this drug access policy was based on economic evaluation, more specifically into cost-benefit analysis. So it was part of a much larger trend to economize or use the economics or microeconomics as the main tool to prioritize in health, in contrast to the political prioritization we have seen in the 70s. And last remark is that if primary healthcare policy has actually survived in a place like Kerala, it is now facing new challenges and new challenges which are not only to health policies, but to development more generally. And what I'm thinking of here is the questions of the multiple ecological crises and the limits of growth. And I stop with that.